So one of the things I like to do is look at things and think what caused them. That's the way you treat them. So for you residents in the room, you know the name of this syndrome. This is the Favre-Rocachot syndrome, if I can say it correctly. And it's considered to be solar elastosis with solar comatose. Well, when I started my medical training, I saw this 5 times a day. Now I don't see it at all. How come? If it's due to sun, the sun is hotter now, it's white, it's not yellow the way it was when I was a kid. There's more UVC. We don't talk about how UVC affects the skin or skin cancers, but if you have a light meter, look at the UVC levels, they're way up from what they used to be. And so, what other part of the body, if you were a resident or a young dermatologist and you saw a guy like this, what other part of the body would tell you what causes this? It's clearly not sun. And why does it go down? Why don't we see it the way we used to see it? Well, this is the part of the body you're going to look at. I always ask the patient to see his fingers because they're nicotine stained. What causes this syndrome is smoking. It has nothing whatsoever to do with the sun. That's why, since it was very popular, now it's not. It's because people stopped smoking. Your best ad, this is from previous meetings, I've shown you all this, is you treat solar lentigines on an old lady's hands, but you only treat one hand. And you don't ever come back for 6 months. And she will go to every single bridge party and meeting, and her friends will ask, how come one hand looks so good and the other hand doesn't? It's because you only did one hand so that she would be advertising for you. And the way you do it is with liquid nitrogen, not a laser. You go psst, that long, psst, 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 to each one, and they all fall off in 2 weeks. This is one I've told you before also, one of my very favorite things I invented years ago. You take Adrasil, which is injectable 5-FU, it's $2.50 for 10 ml, and you mix it with 10 ml of Cetaphil cleanser for oily skin. When you mix the two together and just stir them around with a Q-tip, you get this very elegant gel. It's a beautiful gel. It's much better than any cosmetic product of 5-FU, and it costs the patient nothing. You make it in front of them, you hand it to them, it costs you $2.50, and they, if they've ever had 5-FU, know that a tube of it costs $150. Chondrodermatitis nodularis helicus chronicus, love to say that. It's a pressure ulcer on solar damaged collagen. Many, many remedies for it to take the pressure off. If you take the pressure off, 87% of patients will be cured. And so instead of having them buy expensive pillows or do this or that, I go to the surplus store where they sell foam, and I buy pieces of foam, and I cut a hole out in the middle of one, and I have a stack of them in the office, and if someone has CNCH, I show them the foam pad, put it between your pillow and your pillowcase, so there's a little hole for your ear. I give them the foam pad, almost always cured, rarely not cured. So for those people who have emoticons on their phone, this is a perfect meeting for Botoxicons. This is from DermChat, or RX Derm. We're talking about this in the last week, so I thought I'd bring it up to this meeting. Selenium sulfide for the treatment of hyperkeratosis. Selenium sulfide, just the 2.5% detergent shampoo, can be rubbed into the skin for 10 minutes, just as like a lotion. You have the patient rub it on hyperkeratotic areas and do this every day. After they wash it off, they apply Vaseline. Good time to do it is before bedtime at night. And so here are some of the cases from that article. The right leg of an 80-year-old African-American man, very hyperkeratotic after 2 weeks of selenium sulfide. The left plantar foot of a man who had Unna-Thost syndrome. These are just pictures out of the article that we're talking about on RX Derm. And here's a woman, an African-American 38-year-old woman who had this kind of keratotic sole. This is the kind of stuff we see every day in medical dermatology practice. And I looked up, I did a literature search on the mechanism of action. The only thing I could find was an old article on psoriasis in which they said it slowed down keratinocyte proliferation. So I put this in for Julie Woodward and all the ophthalmology residents, because every year there's so many of you, and thank you for coming to this conference, about treatment of periocular basal cell carcinomas, because my boss, Rivka Issaroff, asked me one day in clinic how fast the basal cells grow. I do surgery for the VA. And I said, 1 millimeter a month. And she said, do you have some literature to back that up? So I did a literature search, and what I found was basal cell carcinomas around the eyes, the eyelids, grow faster than other basal cells in other parts of the face. So this is a very high-risk area. That was just the conclusion from that article, saying that they have aggressive subtypes and they grow fast. So this is kind of a lunch loser. This guy came to our clinic 3 years ago, looked like this. He was scheduled for Mohs surgery. He didn't come back. He came back 3 months ago, and this is what happened. And I talked to him, and I said, do you mind if I show your pictures at conferences? I don't care. Why did you neglect this? Why are you in this position? He said, I was crazy. I was insane. I was a hoarder. I locked myself in my house with all my possessions, and one day I woke up and looked in the mirror. That's why I'm here. So what's the treatment? How do you treat something that's untreatably bad? Well, back in 1986, Hugh Greenway and Roger Cornell published this article about treatment of basal cell carcinomas with intralesional interferon. And this is a picture from their article of a big basal cell on the chest. The side effects of giving intralesional interferon are flu-like symptoms. The patients get malaise, fever, chills. They feel like crap for 1 day, basically, not very much longer than that. And this is from Greenway's article, a list of side effects. A student of mine who was rotated through my office through my residency program when he was a student, Steve Tucker, took the ball and ran with it. And he has done interferon treatment and written about it for years. So how his program works is you do perilesional around the tumor, 1.5 million units of alpha-2 interferon once a week. Not in the tumor, around the tumor, once a week. When I do this with my patients, I put them on Benadryl. I have them take 50 milligrams of Benadryl every 4 to 6 hours, and aspirin a couple times a day. Markedly decreases the flu-like symptoms. Steve did a long-term follow-up, and in his long-term follow-up, I'll show you some of the results. There were 98 biopsy-proven primary and nodular BCCs that were followed up. 95 of the 98 tumors were free of tumor at the follow-up visit, which had a median time of 10.5 and 12.5 years, respectively, with a range of 9 months to 18.5 years. 3 tumors required further treatment. Of the 68 tumors with a minimum of 10 years follow-up, 67 showed a response to treatment, 99% response rate, and there was an overall 96% cure rate. So this is from his article. If you look at the cure rates for all the ways we treat basal cells, perilesional interferon over a long time had a 96% cure rate, better than surgery, a little bit less than Mohs. And for some reason, this didn't catch on. And I think the reason it didn't catch on is this slide from his article, is that it requires 9 office visits, 1 week apart. The patient buys the alpha-2b interferon. I give them a prescription. They go to the drugstore. Cost about $250 to $300. Medicare does pay for it in most of the patients I've treated. So it's office visit cost. And I don't charge anything more than just an office visit because it takes 2 minutes to go around the tumor with your aliquot of interferon. So that's for you eye residents. American Journal of Clinical Dermatology in 2018 wrote an article about daylight PDT. Many people on this program have mentioned they use PDT. I remember Melanie Palm yesterday or the day before said she always starts off her skin rejuvenation with PDT. It hurts. Most people don't like PDT, but daylight photodynamic therapy doesn't hurt at all. And for some reason, it hasn't caught on. And what you have to tell the patient before the treatment is the difference between UV light that gives you a tan and burns you, and visible light, which does nothing, and that they're going to have a big problem if they don't use sunscreen and do the treatment appropriately. So the peak on this graph is protoporphyrin spectrum, and you see it's different from UV spectrum. It's in the visible light spectrum. So you have a discussion with the patient, and you tell them all about the treatment. I use Carasticks because that's what we have available. And if you send them home, there was a German study that did a back and forth with patients. send them home with this treatment, 50% of them don't get it. They keep calling your office, they don't understand how to do it. It's very similar to the psoriasis patients I talked about last year. You give them all these instructions, and they somehow miss the boat. So basically, we have them come to the clinic, and we put the Cara sticks on them, and we put a chemical sunscreen, not a barrier sunscreen, and they go outside in the visible light for 2 hours. And this is what the patients look like before, after, during treatment on the top picture. So there is no evidence, there is no study that shows the time you should do this, and there's a consensus among all the people that do daylight PDT, 2 hours of daylight. And you have to put the sunscreen on immediately. If you wait a while and protoporphyrins build up in the skin and they go out in daylight, they're going to be in a lot of pain. So on the left of your picture is the daylight PDT showing the very satisfied compared to regular PDT. Pain is almost negligible. The keratoses resolve the same as they do with blue light PDT. And on the bottom, there are little pictures of sun exposure. It doesn't matter if it's a cloudy day, sunny day, doesn't matter. Doesn't matter what the temperature is. Last year, I talked about the bile acid and bioflavonoid treatment of psoriasis. A bunch of people asked me, are you going to talk about that again? I wasn't going to, but I put it in because I was asked by so many people here. This statement that you can read was the last paragraph in my paper. And I've had, after Doris Day did a national radio show with me, and I did a couple other podcasts and radio shows, my email just filled up with patients from literally all over the world wanting to work with me on how to do this. And I tell them, I'm glad to work with you. Send me pictures, tell me what you're doing, give me a history, I'll tell you what to do. And here's my article, read it so you understand it. And basically what people were attracted to when they read this article was the fact that I told them psoriasis is an inconvenience, not a career. It's a career for most people. It's only an inconvenience if you treat them the way I do. And this is a letter I got, one of, I don't know, hundreds, from a young man saying he had psoriasis for 15 years, and after only 6 weeks on his protocol, his skin was 100% clear. And he says, I'm really happy with how it looks now, and I just wanted to thank you very much for the success of your treatment. And here he sent me, I said, okay, send me pictures. So he sent me some pictures before and after of doing this at home. So the treatment is based on basically 2 articles. We can condense down everything I said in the article onto 2 focus points. This one, you've all heard about at this meeting if you're regulars. This article is the reason why ice cream works to decrease bleeding after surgery. Ice cream is high fat, high sugar, and it has emulsifiers. Emulsifiers are the worst at causing intestinal absorption of endotoxin. This study was, I called the McDonald's study, because patients were studied that had a high-calorie, high-fat breakfast at McDonald's compared to people who didn't, and compared to people who drank orange juice with their meal. And it turned out that patients who drank orange juice with a high-fat, high-calorie meal had no big rise of endotoxin after the meal. The people that didn't eat the orange juice had endotoxemia after the meal. And this is part of the study where they gave these patients glucose and water, or orange juice. And the bottom of the graph shows the endotoxin rise after the patients had orange juice with their meal. So bioflavonoids from orange juice, you can buy citrus bioflavonoids, called citrus bioflavonoids on Amazon. I use quercetin because quercetin is the backbone of all citrus bioflavonoids, but you can use either one with every meal. This article, I just showed you the Hungarian article about treatment of psoriasis with bile acids, is the other article that's of importance here. Bile acids split endotoxin into non-toxic fragments. And that's the study I cited. 800 patients were treated with bile acids, and at the end of the study, 78% of them were asymptomatic. The patients were put on a special diet. No pepper, no red pepper, no horseradish, no bay leaf, spirits, raw onions, garlic, and carbonated soft drinks. The most important in that list is pepper and spirits, alcohol. I've had patients corresponding with me who've gotten much worse when they ate onions or much worse when they had a lot of soft drinks. So those things are legit. But the two biggies, pepper and alcohol. Psoriasis is made worse by these because they cause endotoxin absorption. Pepper will ruin a D-xylose absorption test. If you give somebody pepper and D-xylose, all the D-xylose will come out in their urine, which means it got absorbed. It's not supposed to be absorbed. So of the 249 patients who received conventional therapy, 24.9% were better, but the bile acids caused 95.1% complete recovery from psoriasis. And the actual results of the study were better than that because the patients that didn't come back were contacted a year or two later, and they didn't come back because their psoriasis was cured. So in the original study that I did and that mimicked the Hungarian study, I used ox bile, 500 milligrams, available on Amazon. I have no brand preference. And I switched just after this talk last year, or at the talk, to Duozyme, because Duozyme doesn't say ox bile on the bottle. Ox bile offends some people. Duozyme looks like nothing, but if you look at the ingredients, it's a bunch of digestive enzymes, and then down there at the bottom, ox bile, 120 milligrams for 2 pills. Some people get diarrhea with 500 milligrams of ox bile, so I start with Duozyme. If they aren't improving as expected, ox bile, 500 milligrams. I got a minute and a half left. Is that right? Quickly, amoxicillin in the treatment of acne was written up in the International Journal of Women's Dermatology by a woman, obviously, and she said that 82% on the face, 85% on the chest responded to amoxicillin. She didn't have any references to all the literature that came out in the early 80s about this, using ampicillin. This one from Shore talking about treating women with papular acne. This one saying he's treated over 100 patients with ampicillin, no serious side effects of any kind. This one about ampicillin in pregnancy. It works fabulously well. In my practice, I don't treat people with fluconazole by itself. I treat them with amoxicillin. The combination of the two is as effective as Accutane. I guarantee it. Try it sometime. You won't believe it. The fluconazole, 400 milligrams once a week for 3 months. The amoxicillin, 500 milligrams BID. Why fluconazole? It's because of this article that came out. Bill Danby turned me onto this. In 1988 in the British Journal, they took patients with acne, they made a clear plastic template, they put it on their back, new lesions were circled on the template, and then 3 days later, they were examined again. The lesions that came up were biopsied at 1 day and 3 days, and in the 1 day and 3 day, Malassezia furfur, pityrosporum, was equally as present almost as C. acnes or P. acnes. And so Malassezia is just as much of a player in acne as P. acne. So you treat them both, and you get a killer effect, gets rid of acne just as well. Honest, I promise you, just as well as Accutane. You'll love it. Thank you so much for your attention.